In, uh, in unicuspid valvular stenosis, only one chamfer is attached to the aortic wall. The chamfer may be any of the three possible normal chamfers. In addition, one or two rafts representing abortive chamfers may be present. A unicuspid aortic valve is intrinsically stenotic. If the chamfer is partly fused, the valve orifice can be enlarged by a chamferotomy. If not, a short incision at each raft may be necessary to enlarge the aortic valve orifice. A short incision may result in an appreciable opening of the aortic outflow orifice, because flow is a function of the force power of the radius. This is not dissimilar to what balloon valvuloplasty can often achieve with a good opening of a stenotic valve and a smaller degree of regurgitation, thus providing the platform for further growth. Stenosis of a tricuspid aortic valve is a rare entity in infancy and childhood. The valve is often deformed and chamfers are fused to varying extents. Incisions are made along the fused chamfers. If there is doubt as to whether a stenotic valve is tricuspid or bicuspid, it should always be treated as a bicuspid valve. An anatomical and echocardiographic analysis of critical stenotic aortic valves in infancy lead to the development of techniques of extended valvuloplasty. The incision of the fused chamfer is extended in a circumferential fashion beyond the chamfer into the aortic wall around the insertion of the aortic leaflet for a distance of 1 to 3 mm on both sides, splitting the aortic wall in two layers and thus giving more mobility to the valve. Aortic valve repair in children. The advantages of aortic valve repair include growth potential, avoidance of anticoagulation, and delay of at times inevitable aortic valve replacement. No single technique can reliably achieve suitable results in all patients. Available techniques for aortic valve repair are commissural resuscitation, partial commissural closure, triangular resection of redundant leaflet tissue, annuloplasty, resection of RAF, and autologous or bovine pericardial augmentation of aortic valve cusp. Repair techniques also include a procedure on the sinus of Valsalva, sinotubular junction, and supraaortic region in patients with dilated aortic root. Intraoperative transesophageal echocardiography is the mainstay of assessment in operating room. This may make aortic valve repair an exercise of trial and error. The most important issue is to achieve effective delay of the inevitable valve replacement without undue compromise of myocardial function. Aortic valve root replacement in the young. Replacement of the aortic valve in the young age group is one of the most challenging problems for the cardiac surgeon. In infancy and childhood, as there is no other suitable alternative in terms of valve growth, the Rose operation is the procedure of choice at our unit with excellent functional results in the majority. We have also found the pulmonary autograft procedure very versatile in the setting of concomitant complex left ventricular outflow tract obstruction. However, some current work provides evidence that autograft root dilatation is not an uncommon phenomenon late after the Ross operation. It may be associated with autograft valve dysfunction, leading to regurgitation that increases with time. Possible explanations include technical error, lack of support of the annulus and sinotubular junction, and valve mismatch with dilated native aortic root. Another important issue is aortic valve substitution in the adolescents and young adults with adequate aortic annular dimension. The options are prosthetic aortic valve replacement, insertion of an aortic valve homograft, aortic root replacement, and pulmonary autograft aortic root replacement. The disadvantages of aortic homograft are early calcification, no growth, and difficult reoperation with coronary reimplantation. Regardless of the type of mechanical valve implantations, the constant hazard is the risk of hemorrhage and thromboembolism. Bioprosthetic valve is not used at our unit because of the known risk of early calcification in children and adolescents. Nevertheless, pulmonary autograft in this age group is not without concern because patients with bicuspid aortic valve often have a dilated aortic root. This may be a contributor factor for late autograft valve dysfunction. Annular hypoplasia, discrete or diffuse left ventricular outflow tract obstruction, and previous prosthetic valve or homograft root surgery would also warrant concomitant enlargement of the aortic root and outflow tract surgery regardless of the types of valve substitution. Aortic valve replacement. Aortic valve replacement operations are performed on hypothermic cardiopulmonary bypass with cold blood cardioplegic arrest. The aorta is cannulated high at the level of the innominate artery. A single arterial venous cannula or two caval cannula are used for the venous return. The cardioplegic solution is first infused into the root of the aorta. If there is no aortic valve regurgitation, and later directly into the coronary arteries when the aorta is opened. If there is aortic valve regurgitation, the first dose of cardioplegia is also infused directly into the coronary arteries. The left heart is vented via a left atrial catheter. For a prosthetic valve replacement, the aortotomy incision starts as a vertical incision below the aortic clamp and curves down obliquely into the center of the non-coronary sinus. Two traction sutures are placed on the lower margin of the aortotomy incision and tied to either side of the pericardial edge, and one suture is placed on the superior aspect of the aortotomy incision. If a homograft valve is to be used, the aortotomy incision stops 10 mm above the top of the commissures to allow room to sew on the pillars of the homograft above each commissure. Although the free hand subcoronary aortic homograft valve insertion is currently seldom performed, it is surgical principle upon which many aortic procedures have developed is described for completeness. Aortic homograft valve insertion. The technique of insertion of homograft valves was initially described by Duran and Gunning in 1962 and by Ross, who reported his initial clinical experience in the same year. The aortic valve is excised. The cusps are trimmed completely flat except for the region of the membranous septum, where a small margin of cusp tissue is preserved. The diameter of the aortic valve ring is then measured with an obturator. It is important to choose a sizer that will rest just within the annulus rather than falling into the left ventricle. The selected homograft should have an internal diameter about 2 to 3 mm less than the diameter of the aortic annulus. The cryopreserved homograft is then taken through the standard sewing process. When it is completely thawed, it is trimmed of excessive tissue. The lower margin consists of the anterior leaflet of the mitral valve and the muscular septum. The mitral valve is first cut straight 2 mm below the nadir of the aortic cusps. Now we will go to the figure in the right 37.4. Here the homograft, and it is trimmed from the mitral side. This is the trimmed version, and this is the C and D. We will read after several minutes. The cardiac muscle is trimmed to leave a sewing edge 2 to 3 mm thick, which is strong enough to hold the sutures. The valve is held on the index finger. The myocardial tissue is thinned out. The depth of the thinning is gauged with the thumb and index finger. Superiorly, the aortic homograft is transected 5 mm above the tip of the commissures, 37.4 B, and then the aortic sinuses are removed, making U-shaped incisions and leaving a rim of 3 to 4 mm